Hello and welcome to this VetLit podcast. My name is Simon Cook. I'm a criticalist here in the UK, and joining me today we have Anna Ylhäinen, a doctoral researcher and clinician from the University of Helsinki Veterinary Teaching Hospital in Finland. Today we're talking about the role of antimicrobials in dogs with pyometra and how, or even if, we need to use them. Anna and her team recently published a study entitled Placebo is non-inferior to postoperative antimicrobial treatment in uncomplicated canine pyometra. This was a double-blinded, randomized control trial in which all dogs received a single dose of TMPS pre-surgically, but after that point they received TMPS or placebo. After a brief chat about the far more conservative approach to antimicrobial usage in Finland and the Nordic countries in general compared to many other countries, what I wanted to glean was Anna's current practice, so that's where we'll begin. Anna, thank you very much for joining me.
Thanks for having me.
So, before we even go into your study, what is your quote unquote standard approach to the dog with pyometra, your prescription of antimicrobials in those dogs?
Well, especially after having done the study, I still use one single dose of perioperative surgical antimicrobial prophylaxis, just because we don't really have the data to be sure that it would be safe dropping that off the regimen, although I suspect it might be. But I do not use postoperative antibiotics in these patients unless there's a really good reason to.
Okay. And is there a population in which you do?
That would be the patients that are septic or have peritonitis or have some other reason why they would be more susceptible to any infections.
Okay. So that's quite an interesting start point to move into the study really, because your study was very much focused on post-operative antimicrobial prescriptions. Your outcome measures were surgical site infections and urinary tract infections on follow-up. But even that is quite interesting, right? You don't actually have the question, will there be any difference in their outcome or in their in-hospital management, for example? Is that because, as far as you're concerned, that question is already answered? And were you already practicing like this before the study?
We actually wanted to look at that as well, but it turned out that every single patient had a pretty good outcome and didn't really require any prolonged hospitalization. So we didn't really get enough data for that question.
Okay. Okay. Well, let's start moving into the study itself then. So, can I ask you just for a brief overview of the goals of your study and the methodology that you chose to try and secure those goals?
So our hypothesis was that placebo treatment is not worse than antimicrobial treatment in preventing surgical site or urinary tract infections in these patients. And we randomized our RCT or our clinical trial patients into two groups, ones that got placebo and ones that got trimethoprim sulfa, because that's what we use here for 5 days at the exact same dosage. So the tablets looked exactly the same. They were in the similar package, and not the treating vets or the owners or even us doing the study knew which one they were getting. And we followed them for 12 days for urinary tract infection and 30 days for surgical site infection. And then after we collected all the patients and saw all the outcomes, we opened the randomization data and saw which ones were getting the antibiotics and which ones were not.
Brilliant, really nice, thorough protocol there. It's really impressive to see that in practice. So then, before we go too much further, I might just ask very briefly about the principle of a non-inferiority trial, because that's what this was, isn't it?
Non-inferiority trial where, well, in traditional studies, you form a hypothesis and then you try to disprove the null hypothesis and you try to have a statistically meaningful difference between the two groups. But in a non-inferiority study, we sort of try to do the opposite. So we're looking for a result where there is no statistical difference between the groups.
Okay. And I suppose that's because the goal isn't necessarily to prove that something is better. There's no expectation that withholding antimicrobials would be better than giving antibiotics. So then it's not even the intention to try and prove that it's better. You just ultimately want to show that the new treatment without antimicrobials is not inferior.
Exactly.
And I suppose that it seems to me that those sort of trials, they have a place where you're not specifically aiming to show something is better because there's no expectation that it's better, but actually the new protocol, the new plan, the new treatment, whatever it is it comes with hidden advantages or other advantages, and those in this case being limiting our antimicrobial prescriptions.
That's right.
So what types of cases were you recruiting specifically?
Initially, we started recruiting every single dog that came in with a pyometra, and that was to have surgery for it. And we have all of those patients within the sort of larger study population. And then from that population, we excluded patients that had peritonitis or sepsis or some underlying diseases or medications that would predispose them for any infections that might affect the outcome of the study. And then everyone else was included in the study.
Okay, so I've got a brief fly through here of the types of patients that might not have made the cut. So those where there was genuinely a septic peritonitis. If a patient was classified as ASA grade 4 or 5, so the real sickies in the sort of spectrum of patients that we might see, and also those with a temperature above 39.4 and leukopenia or hypoglycemia. So I suppose we're describing just the sicker cohort that you're trying to
Yeah,
exclude.
yeah. And that's the sort of our septic criteria, which are kind of fluid anyway.
Yeah, absolutely. Yeah, they
But
are.
that was
They
the
are.
sort of surrogate for sepsis was
Yeah.
the fever and leukopenia.
Okay. And do you have an impression of how many of those you did have to sort of get rid of based on them being too sick to meet your inclusion criteria?
We had 207 dogs in the initial cohort, and then out of those, 32 were excluded for peritonitis or sepsis or a higher ASA class.
And does that fit with what you see clinically as well? That roughly that proportion of dogs you see are, quote unquote sick, quote unquote septic. We won't go into those topics today, but that fits with the proportion of them that you're seeing clinically that are sick versus the proportion that are relatively stable when they get to you.
I think so, yeah. So that's about 15%. Yeah, most of them are doing clinically pretty fine when they present to emergency.
Yeah, brilliant. Okay. So then you've ended up with 153, 152 dogs. You've randomized them to receive a single dose of TMPS perioperatively and placebo following, or a single dose of TMPS perioperatively and antimicrobials for 5 days ongoing.
Yeah.
Brilliant. So then tell me what you found when you followed those dogs up over time.
So we did a follow-up exam at around 12 days. We asked the owner how the dog was doing and had there been any signs that might be adverse effects from TMPS or if there were any signs of urinary tract infection clinically or anything like that. And then we examined the surgical site as well. And then after that, we interviewed the owners at around 30 days after the surgery about the same type of clinical signs. And if the dogs had any suspicious clinical signs that might have something to do with any type of infections, we invited them for additional follow-up.
Okay, and so then at the scheduled follow-up times, what did you find with regards surgical site infections and urinary tract infections?
Not much, to be honest. We had very few infections in the whole study group of a bit over 150. We had three clinical urinary tract infections and 8 surgical site infections in total.
The cool thing about those, so that I've got the eight dogs with the confirmed surgical site infections here. So four of them were classified as very superficial, one of them being in the placebo group, and then three of them being in the active control group. So the antimicrobials prescribed for 5 days post group. And then the other four were considered organ infections, one of which was in the placebo group, and three of which were in the active control, so those receiving antimicrobials post-procedurally. Could you tell us anything about those dogs with organ infections post-operatively?
The surgical site infections were actually really hard to determine, but the ones that did have an organ infection were mostly considered like stump pyometra.
Okay. And then with regards to the follow-up urine sampling, you were following up specifically, like one subpopulation of dogs which you chose to report results on were those that had documented bacteriuria when they were managed for their pyometra. Because I think it's probably even one of your studies from before, but ballpark, we know that around about a third of patients with pyometra will have evidence of bacteria in their urine, should you sample it. And you followed up those ones specifically over
Yeah,
time.
we did. Yeah. The ones that had bacteria in the urine during the pyometra surgery, or if they showed any clinical signs of a UTI after the surgery, then we sampled them at the follow-up as well. We actually looked at that within the entire cohort of 207 dogs, and we had 67 out of those with perioperative bacteriuria, so about a third of them. And then at follow-up, about a third of those had persistent bacteriuria, so 18 out of 56 that we managed to get a sample out of, and 3 out of those 18 had clinical signs to go with it.
Okay. Yeah, very cool. So then, amongst dogs that were specifically followed up as part of this study, because those were results from the same or similar population of dogs that you published previously. I'll make sure those notes that link is available in the notes. But if we looked at those 43 or so, of those 43, you got 16 samples that cultured positive at the 12-day mark. 14 of those were in the placebo and two were in the active control. So, grossly speaking, it looks as though we're culturing more in the placebo. But the cool
Mhm.
thing is that only two of them, both of which were actually in the active control group, so those receiving antimicrobials or received the longer course, had any clinical signs of a urinary tract infection.
Yeah.
So that's pretty cool data, right?
Yeah, I think that's sort of aligning with newer consensus statements that subclinical bacteriuria shouldn't be treated, and that's sort of what we're seeing. So we've treated the ones that had bacteriuria, and the ones that didn't receive treatment still have it, but it's not a problem for them clinically.
Yeah. Do you think there's a case that those dogs with pyometra and bacteriuria, who's to say that actually the bacteriuria wasn't there first anyway and was completely
Exactly.
subclinical always? Is that your current theory?
Yeah, we don't know really, but we did look at the bacteria in the uterus and in the urine. We took 15 dogs with E. coli in both specimens, and also E. coli in either the follow-up urine or surgical site specimen. And we did a whole genome sequencing, and we looked at how closely related the bacteria are, and mostly they are exactly the same strain.
Yeah.
So who knows which came first?
Yeah.
I think that for quite a long time, we've had the idea that pyometra patients always have a clinical urinary tract infection concurrently, and that has to be treated. And actually, when I was starting with the study, we hadn't yet started recruiting patients for it, but I was part of the project. I had a pyometra patient that I operated on. It was fine. There was no complications, and the patient was doing clinically very well. And I did not prescribe antibiotics afterwards. And then I think a day or two after, I received a call from an older colleague who was yelling at me on the phone that how can I not know that these dogs always have a UTI and they always should get antibiotics afterwards? And how can I be so incompetent that I didn't do that and now they have to treat it for the UTI that I managed to not treat?
Yeah.
And yeah, so I guess we've sort of shown that they do not always have a UTI.
Yeah. Yeah, brilliant. I love the idea that it's all very well and good practicing evidence-based veterinary medicine, but it's often the case that practices precede, well, they have to. The clinical practice tends to precede the provision of evidence that is in the mainstream, right? So
Yeah,
actually, off the back of clinical experiences and tighter antimicrobial prescription habits, you've been in a great situation to actually challenge quite a lot of people's concern and their tendency to prescribe based on habit or to prescribe based on precaution. And you're able to challenge that. It's brilliant. We're establishing that you have very stringent antimicrobial prescription habits, and that's brilliant. And I suppose I wanted just to link that in with even some guidelines that might be surprising to some listeners published in the UK. So we do have Protect Me antimicrobial guidelines for patients with pyometra, and the first statement within that section says antibacterials not required if stable and proceeding directly to a variohysterectomy. So even that might well be news to some people, and I think it's aligned with the results that you're reporting here, isn't it? But I'd like to just go off piste and say, do you have any patients, considering that you're probably, I would say, at the forefront of limiting antimicrobial prescriptions in these dogs? I think that's reasonable to say. Do you have cases in which you feel you've been too restrictive? Or actually, has it all been relatively plain sailing in your experience over the last few years of doing exactly what you do, like you said at the beginning?
I think that's kind of hard to say, even with patients that you don't initially start antibiotics on and then they develop an infection. There's really no way to tell whether starting antibiotics at the start would have prevented it or what all the factors that are playing in the development of the infection. And with regards to, I guess, the pyometra patients, previously when I didn't use antibiotics after the surgery, it was sort of only for the patients that were clearly very well. And I think that with this study, we've sort of broadened the population of the patients that we consider doing well enough, because that's always been sort of hard to distinguish the line between the ones that aren't doing well and the ones that are.
Yeah.
And I've seen people or heard people say that if they have a fever or if they have leukocytosis or if they have left shift or if they have a very high CRP, then they are considered like doing worse and they should get antibiotics. But these patients in this study were included in the study and they did perfectly well without antibiotics as well.
Okay, great. So patients included in your study sometimes did have the pyrexias or the leukopenias, but they wouldn't tended to have had those combined or been pyrexic, leukopenic, and hypoglycemic. It's that population that you did exclude, but if they had those things in isolation, you tended to include them. Is that right?
Yes, that's right.
Okay, perfect. So now, an intentionally thought-provoking question. Every dog received a dose of TMPS IV in your study. How much do you think those animals even needed that dose?
That's a very good question. I think that the Swedish guidelines actually state that even the perioperative antimicrobials should be withheld in the patients that are doing clinically well. but I haven't seen any studies looking at what the effect actually is. There is one Swedish study at least that has a higher incidence of surgical site infections in the patients that didn't receive perioperative antimicrobials. But who really knows when it isn't studied?
Yeah,
But to be honest, if the infection rates are that low in these patients, I really sort of doubt that it's actually useful.
that would be really cool to see some evidence on. I guess I like to think about these patients from the perspective of they've often been clinical for a few days, right?
Hmm.
If they've had clinical signs for a few days, they come in at whatever, day three of clinical signs. We give them antibiotics, take them to theatre, stop the antibiotics. What's the difference between that patient coming in just a day earlier and having surgery without any antimicrobials and then going home, and the patient staying at home for an extra day without antimicrobials and then coming in and having the treatment?
Yeah, that's it, isn't it? But then you sort of have to think about what your aim is with the antimicrobials. What are you trying to treat or prevent?
Yeah, brilliant. Okay, some wrapping up questions now. So what if I said to you, what barriers do you anticipate, or what barriers do you actually encounter from clinicians who do feel uncomfortable stopping their postoperative antimicrobials?
Well, I think it's always hard to change your treatment protocols, especially when it's de-escalating the treatment, sort of. And I know I've heard a lot of people commenting that when we did the study at the university hospital, our um, surgical asepsis standards are higher than at maybe a private clinic or any smaller practice. And maybe the patient material is different as well. We tend to see the patients fairly early
Hmm.
in the disease process compared to maybe some more rural practices where they only bring the dogs to the vet when they're near death.
Sure. Yeah, no, these are all really reasonable points, aren't they? And it's the same principles underlie any recommendations, any consensus guidelines, consensus statements, don't they? That they actually you have to take them in, you have to use that information and add it to the clinical setting that you're in. If you
Hmm.
are in the middle of nowhere with minimal access to XYZ and a different patient population, yeah, it's really hard to extrapolate, and we shouldn't
Yeah.
be. So yeah, I think that's totally reasonable. What about the owner perspective? What about counseling owners that expect antibiotics? Do you see that, or actually is the culture of prescription so kind of established that it's not even challenged by the owners?
That has actually changed a lot, I think, within the last 5 or 10 years in regards of sort of everything. We used to get a lot of clients coming in and demanding antibiotics for this and that, but now they're not really doing that anymore, at least not in my small bubble here. And when I was recruiting patients for the study, I actually had one client that declined participating just because there was a chance that their dog might get unnecessary antibiotics, and they did not want to take that chance.
Wow.
And I was sort of very happy about that.
Yeah, that's amazing. That's really cool. I don't think I've encountered, actually maybe once, but that is not a common situation where we practice at all. Okay, so what would be, or even is, maybe you're doing it, I don't know, what would be the next logical trial for you?
That's a very good question that I do not know the answer to. I don't have any further plans yet,
No,
but but if you have any good ideas on what we maybe should try to go for next, then we're happy to listen.
oh yes, please. I mean, I suppose the thing that I want to know most is the population, because presumably there is a population of dogs that don't require any antimicrobials at all and defining that population. We've got recommendations, as you say, in Sweden, there is a case to say don't prescribe any at all. And we've got some that if stable and proceeding straight to a very hysterectomy, we've got the same guidelines. But that's quite nuanced and it turns it into a clinical decision, doesn't it, about the patient's stability and which variables we should use to determine a patient's stability. And many people are happy in that realm, aren't they? They're happy saying, "Oh, I think this dog looks stable enough. I'm happy to put my credentials on the line, and to withhold antimicrobials." But not everyone is. So having some objective criteria in those patients would be lovely, wouldn't it? It's a very messy study, and maybe it's something that is actually just accumulated over time, accumulated over the course of people's practicing, rather than a study that we could actually capture the data during. What do you think?
Yeah, I think you're right. And I think that we see actually more in the younger vets that are fresh out of vet school and they're not really too worried about using antibiotics for everything because that's how they were taught and they're just fine with it.
Yeah,
And then they're trying to sort of bring that for the more seasoned colleagues as well, who are then maybe a little reluctant to stop using antibiotics because all the patients that did get antibiotics are doing fine.
yeah, very cool, very cool. And then a final question to wrap up is what feedback have you received so far from the veterinary community? Because I think this is a really exciting study since publishing these results. Who has been in touch, or what feedback have you received?
I think it's been very, very well received overall, and I've gotten very, very nice feedback on it, especially, of course, within my own sort of circles. But I've been very happy to notice that it's been as well received internationally as well, which I wasn't really expecting.
Great. Yeah, I honestly I think it has the potential to be hugely impactful, and that's exactly why we wanted to talk to you today. Thank you very much for joining us. So the aim of VetLit is to make veterinary literature both more accessible and accessed, and hopefully we've secured that in some small way today. Remember, you'll almost definitely find an article to read that interests you on the vetlit.org site. You can check back here, there, or via the email updates for more. And otherwise, have a great day. It's goodbye from Anna,
Bye. Thank you.
and it's goodbye from me. Bye for now.